All right, let me go into total cost of care. Okay, this is my last of the Minnesota-specific terms. If you go into another state, it might be called global payment, it might be called population-based payment, it might be called capitation. But the idea is in total cost of care is actually a nicely descriptive concept. You are making, your payment arrangement is structured around all of the costs, the total cost of care. Under total cost of care payment, a provider entity takes responsibility for both the cost of services and the quality of services for a population of patients. Essentially, the provider is entity, whatever it might be, is accepting responsibility to manage to a budget, but a budget that has some quality strings attached. It's not just a financial budget, it's a quality budget too. It's like bundle payment, except instead of being focused just on a particular condition, hypertension, asthma, COPD, or a particular procedure, it's focused on all of the care, or virtually all of the care, for a population. The goal here is to get some incentive alignment so that there is a reason for the provider to look out for both cost and quality on behalf of the patients that they serve. There are two primary models of total cost of care payment. The first is shared savings, or what sometimes is called an upside-only arrangement. So under this model, the payer and the provider, and the payer can be an insurer, it could be a self-insured employer. They negotiate a budget. Here's how much money we think it should take to care for this covered population for a year. If the provider is able to manage costs so that they come in below the budget, and if certain quality metrics are met, then the savings, the difference between the budget and the actual spending, is shared between the payer and the provider, hence shared savings. It's called upside only because there's no exposure, financial exposure, to the provider if the provider exceeds the budget. So it's a win only. No fear of financial loss for the provider. The other model is a shared risk or two-sided model. The same on the upside as shared savings, but there's responsibility and accountability also if costs exceed the budget target. Now, I'll note that in these arrangements, there are usually protections to the provider, financial protections, because they're not health insurers. Although in Minnesota, some of the providers are health insurers. But generally speaking, most providers who enter these arrangements are not health insurers. And they don't want to be health insurers. So they're not assuming full risk. So there are some ways that the risk is limited. There might be a shared risk arrangement the same way that there's shared savings, there's shared risk on the bottom. There might be a cap on downside loss. Frequently, there are requirements that the provider purchase reinsurance, or that there be a cap on high-cost outliers. So there are ways that the providers are typically protected, but still they are assuming some downside risk. So if they don't manage to their budget, they are financially harmed. Okay? Well, let me ask you, which of these two do you think is going to provide a stronger financial incentive to the provider? Shared risk, right? Okay, keep that in mind as we talk further. Jim Eppel presented to some of you at a community forum in November, and he shared what Blue Cross Blue Shield of Minnesota is doing. Blue Cross Blue Shield of Minnesota has a shared savings or upside-only arrangement with some of its providers. And this is Jim's slide. On the left, traditional payment, all fee-for-service, little tiny pay-for-performance incentive. Not enough to overcome the fee-for-service volume incentive. They've changed their incentives now so that there are separate pools for quality and for managing total cost of care. And the fee-for-service incentive has become diminished. So that's a good thing. It It's not removing the volume incentive altogether, but it clearly is less significant, and quality and managed to a budget become much more significant generators of revenue for the provider. This is payment reform. This is what it looks like. This is just one way, though, and this is only for upside only. How does this work in detail? Because I know that for you as employers, you're wondering, well, so exactly what are the details here? How's the money actually flow? There are two methods of administration. One is the health plan sets the budget and then pays a per member per month fee to the provider entity. Essentially, they are prepaying, and the provider's got to manage to the budget. The second way, and I would say by far the most common way, is the health plan continues to pay on a fee-for-service basis. And then at the end of the year, they settle up. They look at what the expenditures were, they look at what the budget was, and they determine whether the spending came in above or below budget. The reason that most arrangements use the latter is because most provider organizations don't have the wherewithal to take those payments up front and then to administer their own claims. So it's much easier for them to have the health insurer continue to do the processing of claims and then to have a reconciliation at the end. The impact for you, if you're a self-insured employer, well, if it's the first method, the per member per month method, to the extent that the per member per month budget is lower than what spending would have been otherwise, well, then you're going to see a reduction in spending right away in terms of a lower per member per month rate. And you might also, at the end of the year, if there's a settlement, you might also see some additional funds that could go either way. You might have to share in the overage, or you might get additional savings. For the fee-for-service method, to the extent that the utilization drops, you'll see that in your spend right away. But again, at the end of the year, if there's a settlement, if it's a shared risk arrangement, you could actually receive additional savings. Or, I'm sorry, if the provider generates savings, you would be asked to pay for a share of those savings because they're being shared. Okay? If they went over, then the provider's got to pay that back to you in some fashion. That could either be through a withhold or through a reduction in their fees for the next year. I want to note in terms of the quality targets, because I'm talking mostly about the financial budget, but these arrangements all have quality targets built in. Sometimes it's to adjust the distribution of savings, and sometimes, as with Blue Cross Blue Shield of Minnesota, it's a separate pool. I've seen insurers do both. But usually when the quality targets are used to adjust the savings distribution, there's either a gate approach or a ladder approach. Gate approach would say, okay, you generated savings, but you can only get your share of savings if your quality was at least at a threshold or at a gate. The ladder approach says, you generated savings, we'll give you more savings if you did better on quality, and we'll give you a smaller share of the savings if you did not as well on quality, but still above the threshold. That's how the quality targets are usually tied in. So they become quite significant, and they address the concerns that a lot of employers and consumers used to have about HMOs and capitation, which was you got a financial incentive to reduce costs, and so we're going to get stinting and undertreatment. By incorporating quality measures in, there's a need for the provider organization to make sure that no stinting takes place, or at least an incentive that it doesn't take place in certain areas. Yes?
How has an organization like Kaiser Permanente, how are they, first of all, from your vantage point, how are they in keeping costs down since they're vertically integrated? And which of these two models do they deploy to keep down their costs?
So Kaiser is different. Kaiser is a traditional staff model HMO. The physicians who work there are employees, and they get a budget, and then they've got to find ways to incent their employees through their compensation package to deliver care at a quality level and at lower cost. And actually, the point the question you raise lets me point something out to all of you. I said earlier that the design matters, but so does the execution. So I want to give you an execution example here as it relates to total cost of care contracting. Let's say that I'm the CEO of Acme Medical Group, and I sign a contract with Medica, and they are going to pay me on a total cost of care basis, either upside only or shared risk. My employees within the medical group all get their compensation geared to volume. The more patients they see, the more procedures they deliver, the more they get paid. Do I have a problem if my payment incentive from Medica is to manage to a budget, and yet I'm incenting my providers to deliver more volume?
You're upside down before you even got started.
Yeah. And you know what? Most provider organizations in the United States right now are upside down before they get started because they're entering into these new payment arrangements and they haven't changed the incentives for their providers. So if I'm you and I'm trying to promote payment models that are going to be less inflationary and reward quality, I'm going to want to make sure that there's payment alignment that goes all the way from the payments that either you make to the provider or your administrator makes to the provider and the ones that the provider makes to their either employees or their contractors. Because unless there's alignment all the way through, we're going to have failure. So an example of some quality measures, this is what Jim presented in November. I've looked at lots of different payment total cost of care measures. Typically, they represent a dashboard that covers a bunch of different domains, as they've done here. And you'll note that they've included here both quality measures, but also some efficiency measures. The utilization measures at the bottom, they've got incentives around avoidance of potentially preventable events, including admissions, readmissions, and complications, of high-end imaging for low back pain, and use of advanced care directives. So those are combined with measures that focus on chronic illness, patient safety, and preventive care. So it's a nicely balanced set of measures. It's these measures that both give an incentive for improved quality, but also an incentive to make sure that there's not stinting and undertreatment as the provider tries to make sure they come in below budget. Examples of success. CalPERS is the biggest employer purchaser in California. It buys on behalf of state employees and lots of local government entities. In 2010, they did a total cost of care pilot. They partnered with Blue Shield, their plan administrator, with a medical group, Hill Physicians Group, and with a hospital system, then called Catholic Healthcare West. And they said for the 42,000 enrollees who were in, I think, an HMO product in the Sacramento area, they were going to enter a different type of payment arrangement. And in fact, the providers in Blue Shield guaranteed the state that their healthcare costs would not go up the next year. So they set a budget. It was a flat budget. They saved $20 million. The providers worked closely together with Blue Shield. They all described sort of opening up their books and sharing information with one another in a way they had never done. They reduced readmissions, inpatient days, and surgeries. And over 3 years, CalPERS has reported $32 million in aggregate savings, all driven by an employer. Another example, Intel. Intel is working in both Seattle and in New Mexico to advance new payment models and delivery models because they go together. And I want to note that the reason that you want to pursue payment reform is to change delivery. Payment reform is not an end in and of itself. It's to motivate different performance in delivery systems. So in Albuquerque, they partnered with Presbyterian Health System to create a program. They brought together both benefit design and delivery system design. So they created a narrow network benefit They had Presbyterian implement a patient-centered medical home or healthcare home model. And beginning this month, Presbyterian agreed to put a percentage of its revenue at risk for managing care to a budget for Intel's 10,000 employees and dependents. If they perform well, they get the withheld amount back. That's the amount they put at risk. If they perform even better, then they get incentive payments. So they've got some money on the line in escrow, so to speak, so they can try to earn that back, and then if they do even better, then they get additional payment. James Dickey, who I spoke with, said it's time for the employers to step up, and Intel's doing so, both here and in Seattle with similar arrangements with other health systems. So what's going on in Minnesota? Quite a lot. Bayer's Healthcare Action Group, when it created Choice Plus in the 1990s, that was an early, truly innovative total cost of care program. I mean, way ahead of the rest of the country when that happened. Right now, I did work for the state's healthcare reform task force during 2012, and I did a little survey of insurers asking them about their contracting. Some were more forthcoming than others, but what I came away with is an estimate that within the commercial market, the health plans are spending the equivalent of about 1/3 to 2/3 of their spending or their covered lives are covered under total cost of care contracts. Higher percentages in the metro area and lower percentages outstate. Also going on in Minnesota, there are Medicare ACO pilots. They're all being paid total cost of care. And the Medicaid program is beginning to test total cost of care payments specifically for Medicaid beneficiaries. Most of the total cost of care contracting arrangements appear to be upside only in Minnesota today. There are some shared risk arrangements, but they appear to be the exception. So when I asked you earlier, what's the stronger incentive for behavior change? You told me shared risk, upside and downside. There's not a lot of that going on in Minnesota right now. So shared savings says, if we do well, then we get a little pot of gold at the end of the rainbow. But if we don't do well, we still get paid the same way. So there's an incentive, but research shows that fear of loss is a much stronger motivator than potential for gain. So there's movement, and I'll note more movement than in most states in the country, but not probably as much downside risk as is necessary to get true behavior change. Has this had an impact? We don't really know. I mean, healthcare costs the last few years, flattened or went down, but we know that was because of the recession. So it's hard to say yet whether these payment arrangements are having impact or not. I noted my concern, but others have voiced concern to me that the fact that most arrangements in Minnesota are upside only means that fee-for-service is still the primary economic driver. Harold Miller, who worked with a payment reform effort in 2008 in the state, Harold believes that true payment reform cannot be achieved by adding bonuses and penalties on top of what's fundamentally a fee-for-service system. The other thing I want to note, and I think there was a question earlier that went in this direction, is that there's a risk that market consolidation is going to temper the impact of total cost of care contracting. And by that, I mean total cost of care contracting is attractive because you're setting a budget, both financial and quality, for performance. That's good. But in negotiating the budget, if the payer looks across the table and the health system is enormous, let's say in the Twin Cities, and you couldn't really offer your employees a health benefit without that health system in the product, well, the health system knows that. And so they're going to say, well, we'll agree to a budget, but we'd like the budget to be 8% higher than it was last year. And if it's not, you won't have us in your network. And you can't sell a product to all your big self-insured employers and to and to your insured business as well. So know that that's a very real dynamic right now, frankly, all across Minnesota, not just in the metro area. There's a lot of leverage on the sides of the providers. And they use you and your employees as the pawn, because it's essentially a game of chicken. The provider can say, look, if you don't give it to us, we're not going to be in your network, and try to sell that product. And the insurer says, well, I know that if I go to my employers, they're going to say, you have to have them in your network. How can you not have Park Nicollet or Fairview or whoever it might be? So there's a need for you to be cognizant of that and to support your plan administrators, and maybe not directly at the negotiating table, but indirectly, because they're really holding you over the fire. And the health plan decision really every single time to give a higher price in order to have the provider in the network, because otherwise they're going to lose you as a customer. So you've got to be with them through that.
So as you look out across the nation in the field of healthcare reform, what state leads the pack? Who's been the most progressive?
I would say that right now, Massachusetts. There's similar contracting activity in terms of using total cost of care payment, but there's a lot more downside risk contracting. That being said, Massachusetts had the same problem with concentration of provider power that Minnesota and every other state has, and there are real questions about how to overcome that. And this was a topic for the Healthcare Reform Task Force this past year, because it's a challenge to figure out what to do with a highly consolidated marketplace. I also want to say that Minnesota looks a lot better than most states. So while I think that you all need to take action, be glad that you're not in a lot of other states, okay? It's a lot worse elsewhere, okay? You've got a lot of strengths to build on. You've got, generally speaking, you've got good, sophisticated health plans. You've got well-organized medical groups. You've got good public performance information infrastructure. There are other states that don't have a Minnesota community measurement. So you've got a lot of strengths to build on, but I don't think you can sit back and watch it all happen. Yes?
I wonder how different your presentations would be if you separated out clinicians from health plans instead of combining them into providers.
Oh, I'm not. When I say provider, I mean I'm talking about providers of services, not health plans. But are you talking about the problem in Minnesota, or maybe it's not a problem, where you've got health plans and providers merging?
You were talking as the providers have power in the system, but
Yes.
I don't think the clinicians have as much power in the system as if you look at provider as being the clinician.
Well, individual clinicians, no. The power is at the level of the medical group or the health system, the hospital. I really mean it at the system level. In terms of individual clinicians, no, not at all. But the health system that sits down across from Blue Cross to negotiate a contract, they have market power.
And what I find myself wondering as you're talking about this is if there was a way to separate or give the power to the clinicians instead of the business people, would that make some of this different?
You'd need an AT&T breakup. I mean, you already have heavy concentration and consolidation, okay? And I'm not going to say that that's all bad, but that's the status quo. So I think you have to figure out how to work with it, because you're not going to be breaking apart the big systems.
But if the premise of what you're talking about is, I mean, fee-for-service has been the status quo, and we're talking about changing it. Wouldn't we want to talk about changing that structure as well, or does that particular piece of the status quo have to be given as it's set in rock?
You know,
the rest of the stuff couldn't change.
I mean, so long as you can prevent the problem of providers giving prices in a way that drives inflation. I don't know that your health systems are a problem necessarily. I think the payment model is a much bigger problem than the fact that you've got organized systems. And in fact, the organized systems may be a strength in some ways.
I respectively disagree.
Okay, that's fair. That's fair. So pros and cons. Total cost of care payment strongly incentivizes providers to improve quality and keep patients healthy and drive costs down, especially if there's downside risk. It's a systems approach to payment reform that really can move away from fee-for-service payment. It's only going to succeed if providers change the way they deliver and coordinate care. Okay, so the payment reform is not enough. There has to be change that follows within the delivery system. In addition, as I noted, there needs to be alignment that runs all the way down to the individual clinician. So if I, Dr. Baylor, am getting paid and rewarded more for volume, and that my medical group is being incented to manage to a budget, there's a problem. Okay, this is an essential change, and our healthcare system nationally is behind in getting this alignment done. Shared savings may not create the required burning platform for behavior change. I think we have to move to shared risk. And we have to make sure that providers don't assume so much risk that their viability is threatened. In the early 1990s, we had a lot of medical groups that went bankrupt, particularly in California. That's not so. I mean, it's possible for the payer and the provider to structure the arrangement in a way that keeps the provider protected.
And they're not going to have to do it on a fee-for-service? I mean, if you're...
Yeah.
If you're just...
They're going to assume less risk than maybe another larger organization. But there are ways to do this. I mean, you're not going to do it with a solo practice. But you said a group of how big?
I mean, if you have 10 physicians, they can't assume a lot of risk. If you've got a 1,000-physician group,
right, right. So they're going to assume less, but that's okay. I don't think that you need to drive everybody into giant groups. I think physicians are running into giant groups because they want protection and security. But I don't think that payment reform demands that this happen. And frankly, you're going to have some practices, particularly in rural Minnesota, that are not going to be paid on a risk basis. That's okay. You know, if you get the majority of the health system organized this way, that's fine. But you know, I have a close friend who grew up in Redwood Falls, and I don't think that they're going to have a big comprehensive risk contract for however many physicians might be in Redwood Falls. Yes?
Does employer size of employees have a question when it comes to shared risk? If you've got a group of only 400 versus 4,000, is there a difference when it comes to the answer?
Yes, so this is a good question. So if you as an employer want to enter a shared savings or shared risk arrangement directly with the system, then yes, you've got to have enough employees. In Cleveland, the individual employers did not have enough. And they've agreed that for purposes of this shared savings pilot, they're going to pool their risks together, essentially, their lives. And they're going to assume that the health system is going to treat everyone equally. And Tim Kowalski, who I referenced earlier, he said, so how do I sell this to my CFO? Because they don't want us to pay for savings that were generated for another employer, not for us. And my argument to him was, look, if you can move this health system so it's fundamentally delivering care differently, that's a big-time, long-term win for you. Does that mean that there's some chance that you might pay a little bit more, a little bit less than what would apply to your population? Maybe, but your population is too small for us to have any statistical confidence in calculating savings for just your employees. Now, you know, most shared savings arrangements and shared risk arrangements, I think, are going to be negotiated by plan administrators on behalf of more than one employer. And so they're going to be pooling all that risk together anyhow. But if you do want to go at it on your own, you need to have a lot of covered lives with that health system, because otherwise the statistical uncertainty is too great. All right, so let me wrap up because I think I'm just at the time to do so. So I hope I made a compelling case that the fee-for-service payment system drives your costs. It is not good for your budgets, and it may not even be good for the health of your employees' independence. Payment reform means fundamentally changing the incentives that providers see so that they are aligned with goals of cost containment and quality growth. Payment reform is not an end, it's a means to changing care delivery. And so if you advance payment reform, see the effort all the way through and make sure that it really is sparking changes, fundamental changes in the delivery of care within the health systems within the state. I'm going to close with a quote from one of you, actually. Linda did some interviews prior to today's meeting, and one of you said, "The only way employers will have any influence is if they come together. We shouldn't just sit back and pay whatever they tell us to pay." And to that, I would say, amen.